Thank you all for joining. We'll get started here in just one moment as I still see some additional participants joining. All right, let's go ahead and get started, everyone. I would like to welcome you to the GW RhythmX webinar today. We have the distinct honor to have Stephanie Clements join us from Mercy as we tackle a very important topic today, which is really nursing workforce readiness. So let's dive into the conversation today. So first off, we're going to just give you a brief introduction of Mercy, allow Stephanie to introduce herself. I will introduce myself and GW Rhythm X. We'll talk through the agenda and then we'll get into the meat of the conversation. Just a few housekeeping items to have in mind. We will be utilizing the Q&A feature today. So feel free to message in the Q&A for any questions that you may have. We welcome those questions. We want this to be an interactive session. And just as a reminder, we are recording this and we'll share that out afterwards as well. So Stephanie, I'll turn it over to you. Would love to have you do an introduction and talk to us a little bit more about Mercy.
Yeah, thanks, Emily. It's such a pleasure to be here this afternoon. And I have the incredible privilege of serving as our Senior Vice President and Chief Nurse Executive for our Mercy Ministry. Just a little bit about Mercy. I'm so proud to be part of such a progressive organization that was founded almost 200 years ago by the Sisters of Mercy in Dublin, Ireland. So as we move into our third century of care, we are really excited to continue to fold in technology to enhance the way we're able to serve our patients and our caregivers. So I'll look forward to the conversation today and hearing from all of you as well.
Thanks so much. It's truly incredible to think through that you are starting, uh, you know, embarking on that third century of care and just the technology transformations that have happened in that time is truly remarkable. So I'm Emily Will. I'm the nurse executive for GW Rhythm X. And you may be asking yourselves, GW Rhythm X, who is that? So we combined companies earlier in late 25. We brought together GetWell's 25-year history of precision engagement with RhythmX AI, which is really the industry leader in AI-powered precision care. And together, we're forever changing medicine by turning intelligence into impact across every point of care. And so you'll still see the same well-loved Get Well products, but also begin to see some of that AI advancement into the precision care. And what does that look like as we think about patient engagement and precision care going forward in the next 25 years? So today's learning objectives, we're going to tackle how to mitigate anxiety amongst your staff, giving you some strategies to reframe AI as maybe augmented intelligence instead of artificial, emphasizing the role that it can have in handling repetitive tasks. Strategies as far as redesigning clinical workflows. We know that technology without that rework of workflows, it doesn't move the needle. And in today's day and age, we need to have metrics that move and show the objectives, certainly going forward. And then um, we're also going to tag into, how do we develop foundational AI competency, thinking about maybe a crawl, walk, run approach today. So we have a poll that we are going to do. And so if you could go ahead and answer that, we'll share those results. But what is the biggest barrier that you see in AI adoption for your nurses? Stephanie, do you maybe want to share kind of what you are seeing on the front lines as far as what you're seeing as a barrier?
Yeah, well, from a barrier perspective, I think, the most common fear that we see with nursing is that loss of professional identity. And so that's been my personal experience is, will this replace what makes nursing nursing? So that lack of information, I think, creates that fear. So anxiety around, is this watching me or is this helping me? And I think if it doesn't work perfectly, we have to manage that, the fallout from that. And so that tends to be another challenge, and another barrier is if we as nurses see this as creating extra work rather than creating time for us to spend with our patients, then the adoption becomes that much more challenging.
Absolutely. I am trying to, just one second, having the technical difficulty here. Just one sec. Close.
While you're doing that, Emily, I think, something for this group to consider is how fast AI is advancing, and the speed of innovation does not have to equal the speed of adoption. And I'm excited to talk through that because I think that can be another barrier is we feel like things are moving so fast. How in the world will we be able to fold them into the work that we know needs to happen every day? So I think that caution is a strength, not a weakness, because we're trained to protect as nurses. We're trained to ensure that our patients are safe, and so we're gonna by natural default come from a place of protection.
Absolutely. And I think that that really sets the foundation for kind of how we have thought about approaching this conversation today. We know that there's caution. We've seen it in the news, even as far as um, we've seen with labor negotiations in New York, AI was front and center. We certainly are seeing it, AI adoption being cautious, even in television, right? With some of the recent episodes that have come out of the pit. And so I do think that as we start to think about what does AI adoption mean for nursing? One of the things as we were preparing for this webinar that really kind of came into clarity was this idea of how do we align where nurses are today? And sort of this theme arose that I like to kind of call it a model almost, where how do we integrate the heart, the head, and the hands of nurses into an effective AI adoption model? So we know that their hearts are anxious. We know that there needs to be some emotional readiness. I think many of us that have been in the profession for, the last 20 years. We've seen the switch 25 years, the switch from paper to the electronic health records to many different technology adaptations, new things. And I think that some of that we haven't always had a seat at the table as nurses. And so how do we make sure that our knowledge is being leveraged, that we are involved in those strategy sessions? And then, really, how does AI help to enable the care for our patients? And so, as we think about sort of this model, Stephanie, can you share a little bit about the communication strategies and how you're tackling kind of the heart, the head, and the hands of your nurses at Mercy?
Yeah, I'd love to just share. We've definitely learned through by example and through trial and error. So I'll kind of share with you some things that have worked and not worked. Leading with purpose before the product is important. So defining that purpose, defining the why. We believe that everything is connected to our mission, and so as leaders, our ability to tie any initiative, whether it's a new piece of equipment or new technology or a new way of caring for patients, we have to tie it back to the why. So we talk about AI very openly. We talk about it as protecting time for our patients, not as a tool to increase productivity. That's some of the first questions we get is, will I be replaced? Mm-hmm. And my answer to nursing is that I've been sharing this kind of sentiment for years. Patients don't come to receive care, and especially in an inpatient setting, to have a procedure or have an x-ray or have some kind of study done, because we can do all of that outpatient. If they're in the hospital under our care, it's because they need the time and attention of nursing. And so ensuring that we lead with that message, that our role is not changing. We are truly enveloping technology in order to almost, bring light to the fact that that nurse-patient relationship is sacred. And then I've also learned nurses trust nurses. Having nurse informaticists, clinician super users is essential to ensuring that your message is cohesive, but also that you establish trust very quickly. In some locations, we've relied heavily on the shared governance within the organization, and others, it's been things like peer champions, informal huddles, anywhere that we can provide nurse to nurse influence. It's not a one size fits all approach by any means. So I think that the way we talk about the heart, the head, the hands in that run, walk, crawl method is really something interesting, and happy to elaborate a little bit more about that, about just like the building literacy and confidence. But those are some of the early things I could share for sure.
Yeah, absolutely. How do you think your location in Missouri and in the surrounding, kind of St. Louis area, both rural and, a metropolitan health system, do you feel that there's any difference in the readiness that your nurses have based on location or, culture?
I would say yes, we do recognize the uniqueness of our individual communities. And when you're preparing for readiness for an implementation of a new product, it's important to take that into account. And so understanding that our teams may be on different levels of the continuum has allowed us to really personalize the approach depending on the readiness of the community, the resources available. And in some of our smaller critical access hospitals, our leaders wear so many hats, and it can be difficult to standardize an approach that says this role does this every time. So I believe in protocols. I believe in ministry system driven initiatives, but we'll never lose sight of that need to individualize our approach based on the needs of each community. I'm glad you asked that. It's something we talk a lot about, that balance between what's standard and what's community driven.
Exactly. And I think as we think about the future of healthcare, we can't just design for the, academic medical center in the, super in Silicon Valley, right? Or like these sort of technology powerhouse areas. We have to think about our colleagues that are in rural care and maybe what their needs are different as well as um where AI may help to support in those different environments. It can't be a one size fits all approach because of all of those things that you just highlighted there, right? The staffing models can be different, the workflows, the ability of staff that you have. I think about early on in my career. My best friend went to work in a rural critical access hospital, and there were night shifts where she was the only nurse on her unit. And she had an LPN and a CNA. And I take that compared to the academic medical center where I started, where, I had a team of nurses, we had hospitalists, we had the residents that were right there with us, as well as the attending physicians. And it was truly at that point in time where I really realized that nursing, although the same and fundamentally, can be very different in how it's practiced depending on location. So thanks for highlighting that as well. Um, you spoke about, this idea of needing to lay the cultural groundwork. And one of the things that I believe that we really need to do is think about AI isn't as a technology project, right? It's not just we're instituting this new Voicera or whatever tech that we've implemented in the past 25 years, that really this is a point in time where we can have a cultural transformation. So can you talk to me a little bit,
Yeah.
Stephanie, about how you're laying that cultural framework at Mercy?
Yeah, maybe I just start with what happens if you don't do that, because that's
Yes.
some of the learnings. I think that that's fun to share. Without laying that cultural framework, we see, the things that we would all imagine, those predictable outcomes of resistance, workarounds, frustrations. And so that started to really frame, the way we do this, because if we just lay it on top of their workload, it's just going to create a cognitive imbalance and we'll never reduce it. So you see adoption slow, trust starts to erode, and leaders really play an essential piece in sense making, helping the nurses understand that why, and then that how it fits within their practice. So we're not asking initially for any practice changes. We're saying, here's your practice. How does this fit within your practice? And I've also found that if we don't frame the story as leaders, the hallway will frame the story. The story will get created. So
Mm,
being really clear on your story, on your why. And then part of that culture is really finding your champions. And the champions don't have to be the most tech savvy folks. They're the ones who ask the curious questions. They're the ones who are trusted by their peers. And so figuring out who those folks are and supporting them often early, visibly supporting them, that's something else that's really allowed us to be successful in piloting technology, implementing technology, folding in AI workflows, but also creating a space for curiosity. And
mm,
some of the things that we've developed at Mercy have come from the ideas that happen at the front lines. And so I don't want to, underestimate the power of just being visible, being present as a leader. So I think just normalizing the not knowing, like it's okay.
mhm,
All of us started somewhere. We have to normalize not knowing and focusing really on what are use cases. So I
mhm,
like to tell my team, like, what is ideal state for you? And then let's see what we can do with agents or AI tools to
mhm,
help to reduce that burden. And so, I'll ask them, can you explain what your challenges are? And then I'll be like, would you try something new? And that seems to resonate, especially in our leadership team, because then
mhm,
they get excited. They've actually helped design processes and tools that are helping their real problems. So that's sort
100%.
of how we start with that cultural framework. Like, look, this is you. This is to solve the challenges you already have, not to create an extra burden on your heavy workload.
Absolutely. I think that that's so key is really addressing what are the challenges, what are the problems. I was meeting with a colleague last week at a conference, and he is in kind of their innovation space, and so was there looking for innovative ideas, and he actually had a portal where he had asked the frontline staff, name your top priorities. What are your problems? What technology
Mhm.
should I be looking for to solve? And I just thought that was such an amazing way to bring that frontline staff closer to the innovation that sometimes is happening behind the scenes that they may not have visibility for. And so was really inspired kind of by that simple question of just asking and grounding in the true problems of the unit to solve. As we think about kind of creating that safety, the emotional safety, where nurses can express anxieties and things like that, where have you seen your leaders really been able to kind of step in to help promote psychological safety, especially around AI and the anxiety that may be there?
Yeah, so I have a great example of that because as we see the fears reduced, it's incredible how the momentum just picks up. And we have an incredible nurse informatics leader named Cheryl Dennison who, as we were piloting ambient listening technology at the bedside in our med-surg departments, she knew that initially there were going to be so many questions. And so she did something so simple. She just put a piece of white butcher paper on the wall and just let them just write anything, like anything that they're seeing, anything that they're feeling. And she was addressing this as often and as frequently as she could, at least daily. And she didn't require that they type up a big email to her. She was like, take a picture of your wall and send it to me. And then she was in really ensuring that she answered their questions quickly. I think that feedback loop, that fast feedback loop is essential because if our teams don't feel heard and don't feel supported, they will start to, there'll be a negative impact. We don't see technology being embraced. We see it being pushed to the side. Let me go back to the way I was doing things because
Yep.
what you're asking me to do is not working and no one will help. So I'm just so grateful for Cheryl and her willingness to lean in and her just heart for service, serving our nurses. We talked about the heart being at the root of this, and nursing will sniff out a fake too. So if you're not a
For
Cheryl
sure.
Dennison and don't truly have a heart for this, your nursing frontline nurses especially will know it immediately. So I think
Mhm.
as a leader, embracing your own journey and understanding where you are on the continuum of your own adoption is important, so that when you do answer, it's authentic and they know that you hear them and that you care, so that we speak to that heart, we speak to that cultural shift, and we eliminate the fears as quickly as possible.
I think that's such a key call out, right? Is as leaders, we need to do the work too to kind of get the knowledge and grow our competency as we're starting to roll out these new technologies, which I think is a great
Mhm.
shift to how do we address and give the tools and the knowledge to our teams. So could you maybe share? I think that was a fantastic example of just the feedback loop, but maybe kind of walk me through how you're meeting your nurses, where they are as far as technology. How are you helping them to kind of frame maybe a crawl, walk, run approach with this new technology?
I think, again, it's like being okay with wherever you are and making that be the right place. Sometimes we feel like we have to come to a space of technology adoption or of new learning with, like, I already understand the background and know what the outcomes are, and really personalizing the approach for wherever someone is. Now, the thought is, though, that we're going to really crawl in the beginning, and I think also as a leader being okay with that. um, One thing I've learned in this role, having come from community operations for 30 years, is that things do not happen as quickly as I used to make them happen. And so when you're looking at some big project like technology adoption, it's being okay with creating the strategy and then letting it sort of evolve with the teams. And then I would say also essential to that is almost like a PDSA, model where you're constantly going, is what we're doing working? Do we need to
Mhm.
pivot? Do we need to change? That feedback that's continually happening. And so I've seen that, you know, really assist us, but I don't want to underestimate the amount of work that goes into the workflow creation beforehand. So being
Mhm.
really thoughtful about that as well. But I would say our ability to be nimble as leaders is essential.
Exactly, right? And I think it's the ability to both reframe when there are challenges that arise, to keep them focused on, what the end goal is, and knowing that anytime we have a technology adoption, there will be bumps in the road. It's not always smooth sailing, right? I think I can think through many times where it's that trial and error, and it kind of almost goes back to the nursing process, right? Where we're constantly assessing the situation, doing an intervention, and then reassessing and making any adjustments. And I think that's the beauty of nurses as innovators, and why I think we're poised to really help bring AI adoption to the health systems in a different way than maybe past technology has been implemented. And so, one of those things that you mentioned earlier as being key to success was identifying champions. Can you talk to me a little bit about when you have kind of maybe a new AI project or a new technology project? What what are those things or the traits that you look for in a champion?
Yeah, I think that champions are the ones that ask the questions and aren't satisfied until they get answers. So sometimes we can see, when I was managing a unit many years ago, I might have thought of that person as being a challenge, really, someone who's always questioning everything. But when you're wanting to implement new workflows, that's the person you want as your champion. I also like to identify kind of who the informal leaders are on any unit and find the ones who seem the most influential. And sometimes it'll really surprise me that someone is actually an informal leader. So being open to that, depending on your space, I think is really important. And
Mhm.
then walking alongside them, really listening. Like I said, that authenticity is essential to establishing those champions and celebrating the wins, celebrating the changes that happen. Um, uh, Another example I love to share is when we went live with our ED to inpatient handoff tool, which is an AI tool that really allows our ED nurses to properly hand off a patient that they've been caring for in the inpatient space. And we were one of the first, we co-created that process, and we were one of the first systems to implement that. But within the first 30 days of the go live for that, we augmented that tool 42 times just based on that feedback. And it was those champions who weren't afraid to come back and say, hey, maybe move this here. Wait, we forgot to pull in, the family dynamics. Oh, this isn't crossing over. And so being willing to listen to those folks. But the champions often identify themselves, I think, um, that looking for those sort of non-formal influential leaders is really important.
I think that that is such a key thing in it. As I think about, my own career in the tech implementations that I've been a part of, it really those informal leaders can make or break adoption and getting them on your team early and helping them to feel empowered to lead from where they are is such an amazing gift, I think, to those nurses and to those staff members. Um, when you think about how quickly something has been adopted or how slowly something's been adopted, have you had any surprises as far as, technology maybe that you thought or a use case that you thought was going to move the needle significantly and it didn't? Where did you see the slowness come from, or where were you surprised at the speed of adoption?
Yeah, I think I would say, we talked a little bit about the cultural differences in our different communities. So we piloted ambient listening technology in three different communities, three different units, three different spaces, three different team makeups. And the speed at which the adoption happened on a dedicated education unit, a unit that's used to training, answering questions, pivoting, was just exponentially greater than maybe a traditional med-surg unit. And so I would just share that setting the stage for the culture early before an implementation is key. And so now we're starting to look at what are the traits that are what we experience from the leaders on that unit, from the environment, from the care models, the way we make patient assignments, have student involvement, all of that that really ripened that unit for earlier adoption and championing in a way that we hadn't experienced with our first go live. And
Okay.
so lots of learnings from that. I think that, something else that's key is finding those areas that maybe aren't afraid of technology. And I'll use another example. So if you're going to consider ambient technology in your medical record, uh, something essential is that you have good workflows around mobile device use. So, where we
Mhm.
had lots of computers on the wall in every room and lots of access to big, take up space modules, there was less adoption on the part of that team from a mobile perspective. Those teams were less likely to utilize a tool that required them to use a mobile device. And so,
Steve.
um, lots of learning as far as how we assess. I think having leadership understanding of what the process is going to look like, and then finding the groundwork to set, that enhances that process. So again, we learned from early on that first unit wasn't as ready because they were um, they were so used to using uh, the bedside
Fixed
computers.
technology.
Yeah, and
Yeah.
that the last thing I'll say is being really upfront with your team about what their expectations are going into a new technology. And so, if the expectation is this is going to work right away, or maybe the expectation is you're helping to design this product, it's going to be a really
Mhm.
long road. There are going to be bumps, but really underscoring the importance of their participation as co-creators. So lots of learnings on what makes a unit ready for any sort of technology implementation.
I think that's such a great transition for us to think about, the hands and how do we really begin to identify the best use cases, identify where AI enables nursing to remain engaged at the bedside? Where is there automation and augmentation that can happen? Uh, and and with that, how are we making sure as leaders that we're not just bringing in technology on top of a workflow, but really stopping to think through what a new workflow looks like? And also thinking through how do we engage and involve the frontline staff in those workflow redesigns? And care model shifts, right? As we think through the future of virtual care. I was just listening to a webinar the other day talking through, virtual care and the journey that this health system had been on from, how they leveraged virtual nursing during the pandemic to where they are today. And how it wasn't just an investment in the technology, but it was really about changing the workflows and trialing and error, trial and error of workflows. I'm wondering if you can talk to me a little bit about how you are enabling frontline staff to be at the table.
Yeah, definitely a strong shared governance model. So we believe that that starts at the unit level, unit-based councils and facility shared governance, so that we are creating the work with our teams, not for them. Uh, I think many of us probably have leadership stories where we thought we knew what was best, and then we ask the people who actually do the work, and we go, "Oh my goodness, I didn't even take that into consideration." And so sort of testing, with um, subject matter experts. So I think that, you know, that workflow design is what will predict your success. And it's essential to ensure that we have that. We also have a nurse practice, a professional practice council that's made up of more than nursing, that encompasses our entire ministry. And that's where we're divided into 10 professional practice teams and looking at everything from policies to equipment to technology to product use, and even things like, where can AI help us? So it's
Hmm.
interesting that I find as leaders, we think we know, like, oh, I'm going to bring in all this great technology, or I'm going to go to this conference and learn so much and share it with my team and tell them all the things we can do, when really, when we learn the things that we can do, it's where we're going to learn the most by just asking, what do you need? Where are your pain points? Is it having the supplies that you need on time? So can I build an agent that automatically orders, when your par levels get to a certain point? Or is it that we struggle with this sepsis bundle years ago, and so Mercy implemented AI tools that are early detection models for sepsis, which really results in patients' lives being saved, but also reduces that burden for the frontline staff to
Hmm.
pick up on everything that might not fit a traditional model. So all of those things are created by surveying your actual team who are touching the patients. And you and I talked previously about the ambulatory space, and I don't want to leave that out, because it's
Hmm.
so essential as we see care move into more of a um, whole life care model. And we want to ensure that, first of all, we can keep patients out of the hospital. So
Yes.
we're developing tools based on the feedback from our primary care and specialty clinics on identifying patients who maybe need an extra level of support, that we've been able to glean from algorithm development based on their feedback. So there's just so many possibilities on how to ensure that our teams have a voice.
I think that's such an important call out is how do we enable technology across the care spectrum? And that's one of the things here at GW RhythmX that we are thinking about is, what is the technology that that ambulatory team needs to, manage chronic health conditions? How do we improve the precision of that care that's being delivered there? Are there ways that we can improve education and patient engagement to keep patients out of the hospital. But then, as they do come into the hospital, what are those technology needs that are needed to help make patients as ready for care as they can be? And then ultimately, how do we leverage technology to help to transition patients from environment to environment, right? And how do we take kind of that knowledge that that ambulatory nurse might have about that patient who they talk with on a weekly basis? As I think about my time in ambulatory care in orthopedics, that was one of the things that we recognized between my outpatient clinic and our inpatient unit is that we had knowledge to share with each other, and in those transitions, how could we enable that? And I think that it's just such a powerful spot to think about where technology enables that communication ultimately to happen, and how we can create some of that automation that may have been a manual process before. You talked a little bit earlier about, the ED handoff tool. I think any nurse that has worked on a med surg unit has had that frustration with the ED of like, I didn't get the information that you needed. Like, how could you tell me that they didn't have, whatever it might be, or the ED being frustrated that they can't call report quickly. And so that example or the ambient nurse dictation that you're starting to see, um, how are you tracking both metrics and success of those initiatives? And then can you talk to me a little bit about what you're hoping to see from those transformations?
Yeah, I think not just tracking usage, but really tracking time saved, documentation burdens reduction, and then both our nurse and our patient experience. So, as far as both the ED to inpatient handoff tool as well as our end of shift summary, those are saving time with transition. So you can look at your, ED decision to admit to admit time, and with the understanding that the emergency department is not the place to hold an admitted patient. And we know that that creates a lot of risk around quality and safety and adverse patient outcomes. So we've seen a reduction in that time, like patients got a decision to admit, we get them to their room. And then when we look at things like an end of shift summary, it's really important to have that cross functional communication with all kinds of caregivers. So we've got a great summary between our nursing and our physician partners, our physical therapists, our case managers. We just fold all of what happened in the previous shift into a really concise picture of what's happening with that patient. And then really a couple of things with the ambient technology that we're measuring, and one of them is that documentation latency. We're not having nurses wait till the end of their shift and go back in and go, oh my gosh, what did I do? Who did I do this for? We don't create risk around you assessing every patient at 4 o'clock, because you can't do that. And that's, a common thing that we see with the electronic medical record is the time stamping not being accurate to the work being performed. And then we're just capturing all of that silent care that happens that you don't document because it's not a box you have to check, but you're doing
Mhm.
it. You're turning, you're teaching, you're praying with your patients, you're in and out of the room, addressing their family needs. And so those are the things that are captured. I think we're really able to get a more clear picture of the value of nursing when we can capture all of the interactions, not just the ones that the nurse feels required to document. So those are some of the outcomes that we're looking at as far as measuring success.
Fantastic examples. As you think about that ambient piece and the care out loud, can you share any, maybe tidbits or success stories as far as how that change has happened? I think as I think about ambient nursing dictation, that's the one thing that I continue to think about, like, how would I leverage ambient dictation? Because so much of how I practiced was just creating the workflow list in my head of like, yes, their heart sounds are within normal limits. There's S1, S2, they have bowel sounds. It was literally going through the checklist in my head. How have you seen your nurses adapt to care out loud? And maybe can you explain that
Mm.
for the people on the call that may not know that term?
Yeah. So, care out loud would be as simple as me coming in and going, good morning, Emily. Oh, let me go ahead and listen to your lungs. Wow, they sound a little wet. And what's documented is that you have crackles, or it's that translation of the conversation that you're having with the patient. I will say it really helps externalize the thinking, and it helps with the patient interactions. One challenge that we have had is that we realize the need to go back and infuse that sort of thinking into our nursing schools. Many of our nurses were
Mhm.
never taught to really talk out loud to their patients about what they're seeing. We're very task oriented. We've got to get things done, we've got to check our boxes. And so our patients are loving it. So they've got this clinical reasoning that's really visible and shareable, and they understand what's happening, what their plan is. So I think there's some work to do, and my advice to folks who are considering that is start that as a foundational practice, in addition to the utilization of a mobile device,
Mhm.
to ensure that you're capturing what's happening appropriately. I got to go in with a nurse, and we were just having a casual conversation with a patient about just a reassessment for pain. And the nurse said, "Oh, I see that you are eating your lunch." And the patient, "Yes, I ate half my lunch. I only ate about a quarter of my breakfast earlier, but I was hungrier now, and so I ate half my lunch." And so we talked a little bit about that, but that wasn't why we went in the room. However, when we came out of the room, what was documented was a 25% consumption of breakfast and a 50% consumption of lunch. When we look at eyes and O's, and that the nurse was just amazed. She was like, "Oh my gosh, that's not even why I went in there, but now I've got this that's going to pull it into the picture of my overall care and be summarized for the next shift." So really exciting about that. The need to converse will not go away, and I'm so excited about that. Being something that we're going to continue to see is that reconnection, human to human, that I think
Mhm.
we've kind of gotten away from with the implementation of an EMR. I just want to reclaim that time for presence, for joy in
Yes.
practice, and just really connecting critical thinking, that we can't replace with
Mhm.
technology. We can just help bring that back. And the reason that we all chose to do this work in the first place.
Well, and I think that's such a great example too of that documentation, right? It may not have actually ever made it in the chart. It might have been documented as I's and O's or whatnot, but that ability to have kind of that precision of it captured that snippet for that patient, like that can be significant, right? There's just so many use cases where the more I dive in and the more I talk with frontline leaders like yourself, the more excited I get about what the impact can be on the future and how that enables, like you said, returning the joy to nursing, making it less about clicking boxes and checking your tasks off, but really engaging in that critical thinking that makes us who we are as nurses. And I think that's just such a phenomenal kind of way of thinking about how we approach AI and the adoption and where those use cases are going to be most impactful. As we kind of come up on the last few minutes here, Stephanie, I wanted to get your thoughts on, obviously Mercy is doing an amazing job with all of these projects. They are truly transforming care for your patients and for your staff. And for, truly kind of the ministry of mercy, if you will. If you were going to give one kind of, if you were starting your AI journey, your care transformation journey today as a leader, What's the one, kind of piece of advice you would give, or what would be your first 90 days, um, kind of game plan, if you would?
Yeah, I think first of all, being comfortable with wherever you are in your journey. It's not everyone's in a different place, and that's okay. But you have to start somewhere. So I would start by listening, not picking a tool, just listening. Where are our challenges? Make sure you can ask good questions while you're listening to be able to educate yourself about where technology can augment your practice. Maybe identify like one low risk but high value use case that your team could potentially adopt quickly. And uh, again, I'll just make sure we highlight investing in the culture before we really think about capability.
Hmm.
So no matter what, that investment in your culture is going to pay off in dividends, no matter what sort of technology your system or your practice chooses to implement.
Fantastic advice. It looks like we do have a question in the chat. I think that I wasn't the only one whose interest was piqued by kind of the tool for handoffs between units. Is that something that you've developed with your EMR vendor? Are you leveraging a secondary vendor? Can you just talk a little bit more about what that process maybe has looked like?
Yeah, so Mercy really developed that with our EMR vendor, and most of the large electronic medical record companies and have availability for you to co-develop that. So two really essential tools. One was that ED to inpatient handoff tool, where it's taking not just the current emergency department visit, but also pulling in the history within the medical record and creating a great report, if you will, for the inpatient nurse to receive a patient. And then the other was that end of shift note, end of shift summary note. One of the things we used to do when I was charting on trifolds was we would write out the end of the shift, kind of what happened. That was our report. That was our, summation of the events. And we lost sight of that with an EMR. And
Hmm.
you find nurses trying to pull and figure out what's happening with this patient before I can even go in the room and take care of them. So that end of shift summary really gives a good picture. And those were both co-created by our internal team with our EMR vendor.
Thanks for sharing that. I do think that that is, an example of, understanding the problem and then looking for the solution, whether it's your EMR vendor or it's another vendor outside of that. But really starting with the problem and then looking for the solution or helping to co-develop a solution there for sure. In the final 5 minutes, is there any additional questions? Looks like we've got another one. Can you speak about how you've addressed possible unexpected or wrong AI guidance and the possibility of adverse patient impact? Or maybe, how do you make sure that it's responsible AI? Um, that's, I think it's such an important tool for most nurses to understand that and
Yeah,
trust.
well, and creating that trust is important. So I would say laying the framework for feedback and ensuring the importance of the human review. So for all of these AI generated notes, there is a requirement that the care team reads and signs off on that because it's still not perfect, and there are times when there have been inaccuracies, especially early in the implementation process. And the other thing that we've done in our organization is we have a whole multidisciplinary group who are continuing to form our guidance around the use of AI tools in patient-facing materials, be it education materials, interactions, ensuring that our clinicians are not using AI tools as diagnostic tools, but more
Hmm.
as just consultative tools. So lots of conversation around that. And I would say the last thing that's really important is establishing that trust with our patients and
Hmm.
ensuring that they know that there is human oversight, that we are doing everything we can to make sure that we're safe.
Mhm.
But we've had this challenge for years. We've had people chart in the wrong medical record before we even started to implement
Yes.
AI, or we've sent someone home with the wrong paperwork. I think that there's always going to be an element of error, but your healthcare system's ability to proactively um, respond to that is important, but also start to predict where those episodes might happen so that we can
Mhm.
continue to develop processes to prevent.
Yep. I think that's such a key thing. And, as someone that works on the vendor side, one of the things that I would say about unexpected or the wrong AI guidance is AI should be an augmentation of the clinician in the loop. But there still is that clinical judgment to leverage. Additionally, here at GW Rhythm X, we're also engaging with a large group of clinicians to validate our AI models before they head out to our customers and to our patients and to our clinicians. And so that clinical validation is definitely key. And I think that, internally at a health system, having that multidisciplinary collaboration, validation, and then review if there are those errors, right? Just because it's AI generated doesn't mean that it doesn't stop from a safety event reporting in how are we learning. Um, and as we correct things, right, that's what makes AI models better, and enables for, additional kind of safety precautions. So, um, I think that that's probably one of when I've been in the field talking with people, I think that that's some of the biggest fear, right? Is how do I know that I can trust this? And I think your point that there's always been error in medicine, and we do the things that we do to prevent those errors, right? If whether it's medication administration, it's the five rights, it's the review, it's that clinical um, judgment that the clinicians, the nurses have together. And I think that it's such an important um, piece to just continue to empower your teams that just because we're leveraging technology doesn't mean that that clinical judgment goes away.
Now, well said.
Um, so we are down to our final minute. And I would love to get your take, Stephanie, on where or what you're most excited about as it pertains to AI, the future. What's the one thing that you feel like we're just starting to scratch the surface on, and where you think that might take us as a profession and for the
Yeah.
future?
I think it's really like predicting outcomes and being able to share data in such a way that if I show up into, my physician's office with a set of symptoms, it can be quickly compared to other people with my same demographics and
Mm.
same symptoms, and not just, the outcomes can really be directed by quicker treatment plans, more precise treatment. I think we're just on the verge of really that precision medicine piece so that it's
Yes.
not a lot of trial and error like many of us have experienced
Mhm.
throughout our lifetime. So I would say, just yeah, that truly excites me that we may be able to um, address challenges more quickly. And then my hope is that I see in my lifetime lots of prevention. So really figuring out the things that will keep us well and keep us out of hospitals and clinics in a way that just brings that meaning back to life and gives people what they need to live a long, healthy, and fruitful life.
Absolutely. I mean, I think that that is at the heart of why we all became nurses, and why we're all in healthcare and in the profession is really that to see people have healthy and full lives. And that idea of precision medicine is so exciting to me. I think about, those stats of patients, seeing 4 or 5 clinicians before they get their diagnosis and what this may transform for them is truly remarkable. So I think we're just starting to see that the shift and the transformation coming for nurses and for our patients. So I want to just say thank you to Stephanie, to our panel, or to our participants today. Stay tuned. We will be hosting additional webinars such as this going forward, really helping to spread and empower our healthcare teams for the future of AI. So thanks so much for tuning in, and we really look forward to seeing you next time. So thank you so much. Have a great rest of your day, and we will send out contact information. I know that both Stephanie and I are on LinkedIn, and then there's our email addresses if there's anything that we can help with. I know both of us would be honored to partner with you all. So thank you for your time. Have a great rest of your day.
Thanks, Emily.
Thanks, Stephanie. Bye bye.